Good morning. This hearing will come to order. I'd like to welcome everyone, and last week the Subcommittee on Technology Modernization heard from the prime contractors on the programs to implement electronic health record systems at the Department of Defense and the Department of Veterans Affairs. Today, we continue oversight of these programs with testimony from the departments accountable for their implementation. In providing oversight, it's important that we have the proper time to review documents. And receiving the DoD testimony at 10:30 p.m. last night certainly does not optimize our ability to do our job. Accountability obviously is a big part of this effort, perhaps the most important. In the history of failed efforts to implement information technology throughout the federal government, more often than not, technology was not the problem. Rather, it was a failure of leadership and management. The questions most often asked are, after failed technology implementations, were who's in charge, who's accountable to the taxpayers and Congress? And the answers often are a confusion of finger pointing and a leadership vacuum. And after every failed project, there are lessons learned and promises to do better. Before us today, we have the leadership of the respective offices for VA's electronic health record modernization and the DoD's healthcare management system modernization. We also have the current director of the Interagency Program Office. We are at a moment in time when critical decisions must be made in order to advance the implementation of this program. But we're doing so without a fully functioning joint governance structure. For months, this subcommittee has asked for a joint proposal to address the long-standing problems with the existing IPO. And as of March 1st, we now have the Federal Electronic Health Record Modernization Program Office, or FIRM, and we will hear testimony about the initial organizational plans. We have a one-page slide right here about a three-phase plan, but it's hard to find where the governance and accountability is in this plan. We also are missing details about staffing and resources. Based on the timeline for implementation, it appears that it will come too late to address the critical decisions that must be made now. Further, I wonder whether the DoD and VA are invested in the idea of true joint governance and transparency, since both declined to provide feedback on a potential legislative solution to finally create a single accountable joint governance office with a role to promote and facilitate interoperability between the departments for health records and beyond. I hope I'm wrong and that the VA and DoD do want a real solution in a functional governance structure. I'd like to believe after we made this investment are prepared to spend at least $16 billion in taxpayer money on modernizing health records for our service members, veterans, and their families, that we are prepared to do this right. Joint governance is not the only challenge DoD and the VA are facing now. The time for VA's first go live is March 2020, and that is fast approaching. There are many key decisions and tasks that have yet to be completed. We are concerned that the VA has left itself with very little margin for error. There are many lessons to be learned from the Department of Defense, which now has its ongoing struggles, and I hope we will get some transparency about that today. But my questions really come down to these. Why not spend the time to get the governance right? Why not take the time to get the infrastructure in place? And why not leave yourselves room to do the necessary testing and training to ensure a successful rollout? This subcommittee has been clear that we want to work with the VA, even if that means delay, as long as the VA is transparent and accountable. Why insist on leaving yourselves very little margin for error when history is not on your side for successful IT implementations? What is the VA doing to mitigate risk and ensure that the final product delivered to clinicians and veterans is the best it can possibly be, understanding that opportunities for improvement and innovation should be part of the management of the EHRM? I'd like to get these answers to these and other questions, and we are asking for transparency and accountability now to pave the way for implementation ahead and what we owe to our service members and veterans. I thank all the witnesses for being here, and I look forward to their testimony. And I'd now like to recognize my colleague, Ranking Member Jim Banks, for 5 minutes to deliver his opening remarks that he may have. Mr. Banks.
Thank you, Madam Chair. I would like to begin by thanking our witnesses, especially our DoD witnesses, for appearing today. You do so voluntarily, and I sincerely appreciate it. Anyone who watched our contractor hearing last week or any of our subcommittee hearings knows we think that cooperation between DoD and VA on electronic health records is very important. Lack of cooperation has been the graveyard of all of the previous efforts. I have no doubt that it is a high priority for each of you. Case in point, you have spent much of the last 9 months hammering out a joint management structure. I want EHRM and MHS Genesis to succeed. I want to support your decisions, but it is not reasonable to expect this subcommittee to endorse decisions that we have scant details about, decisions that are the product of a secretive process. By all accounts, DoD and VA are getting close to standing up the Federal EHR Modernization Program Management Office, the FIRM, to jointly manage EHRM and MHS Genesis. I understand the desire to make the agreement in private before disclosing anything. The problem is, though, there has been no agreement. Compromise has been elusive because the stakes were so high and both sides were apparently dug in so deeply. My hope was, and still is, for this committee and the Armed Services Committee, which I'm also proud to serve on, to help mediate the situation. No one wanted the firm to be stood up this late, but this is the reality. We are now 4 months out from the go-live dates for MHS Genesis Wave 1 and 10 months out from the go-live date for VA's initial operating capability sites. The opportunity for the firm to have an impact is right now. It is time for a candid discussion of the department's vision to integrate EHRM and MHS Genesis. However, I am more interested in what the firm will accomplish than how it will be structured or which individuals will lead it. I expect it to solve real problems, or better yet, prevent them from happening in the first place. Since taking on this assignment 1 year ago, I have seen and heard enough to have some serious concerns. VA and DoD are different animals. VHA and the military health system have cultures, priorities, organizational structures, and even missions that are quite different. I happen to believe that they should be more closely integrated in the future. But if we force them into a one-size-fits-all solution now and ignore these realities, it may very well break them. Healthcare is a roughly $90 billion enterprise in VA, and it is one of the 3 core missions of the department. Military healthcare is a critical component of force readiness. Both are personally important to me. But electronic health records are simply not central to the DoD mission in the same way that they are to the VA mission. DoD is in a unique position with the creation of the Defense Health Agency and the consolidation of the military services treatment facilities into one organization. I understand MHS Genesis is a critical element in accomplishing that, so preserving the schedule is paramount. I have also seen for myself that ALTA and CHCS are incredibly difficult, unpopular EHR systems. On the other hand, while the structure of VA is not changing at all, the department is implementing the Mission Act, and community care is growing in importance. VA is not replacing VISTA because it works poorly. In fact, some clinicians like it very much. VA is replacing VISTA because it has fallen too far behind to meet the needs of the future. A single longitudinal DoD VA health record would be a major accomplishment. As Dr. Rowe can attest, any EHR implementation is disruptive at best and traumatic at worst. In order for the cost and time and disruption to be worthwhile, VA also needs true interoperability with the community providers. Attaining that 9 years from now is simply not good enough. I believe Congress has a duty to spell out its expectations, and the time to make an impact is right now. That is why I will be offering 2 amendments in the National Defense Authorization Markup Act that's going to occur today. The first puts in place requirements to ensure the firm has qualified leadership. The second calls for DoD and VA to develop a comprehensive interoperability strategy to accomplish specific goals and defines interoperability for the first time. Unfortunately, the Armed Services markup happens to be going on simultaneously with this hearing. And Madam Chair, with your forbearance, I have to be present there to advocate for these amendments. So I'll be heading back there, but appreciate once again all of you being here today for this important discussion. And with that, Madam Chair, I yield back.
Thank you, Mr. Banks. I'd now like to introduce our witnesses we have before the subcommittee. First, we have John Wyndham, who is the Executive Director of the Office of Electronic Health Record Modernization at the Department of Veterans Affairs. Mr. Wyndham is accompanied by Dr. Laura Krupa, Chief Medical Officer for OEHRM, and John Short, Chief Technical Officer for OEHRM. William Tinston is the Program Executive Officer for the Defense Healthcare Management Systems at the Department of Defense. Mr. Tinston is accompanied by Major General Lee Payne, the Assistant Director for Combat Support at the Defense Health Agency. And we have Dr. Lauren Thompson, who is the Director for the DoD VA Interagency Program Office. Welcome. We will now hear from the prepared statements from our panel members. Your written statements in full will be included in the hearing record. Without objection, Mr. Wyndham, you are recognized for 5 minutes.
Good morning, Madam Chair, Lee, Ranking Member Banks, who just departed, Dr. Rowe, Congressman Lamb, your respective support staffs, good morning. Thank you for the opportunity. I am accompanied by Dr. Krupa, ma'am, as you mentioned, who's my Chief Medical Officer, Mr. John Short, who's my Chief Technology and Integration Officer. First, I want to take this opportunity to personally thank you and the members of the subcommittee for your unwavering support of the EHR modernization effort. Without your steadfast support, VA would not be able to deliver this critical capability in support of our veterans. On June 5th, 2017, VA announced the decision to replace VISTA, its existing legacy system, which is costly to sustain and cannot deliver commercially available critical capabilities to meet the evolving needs of the healthcare market. Though the decision, VA is working to adopt the same EHR solution as the Department of Defense, allowing patient data to reside in a single hosting site using a single common system. This initiative will ultimately enable the seamless sharing of health information, deliver enhanced analytics, improve care delivery and coordination, and provide clinicians with the requisite data and tools to support patient safety. On May 17, 2018, VA awarded a contract to Cerner Corporation, leveraging an existing commercial off-the-shelf solution in pursuit of interoperability objectives within the VA, between VA and DoD, and with community providers. This contract contains the necessary conditions to foster innovation and keep pace with the evolving commercial technology. To this end, OEHRM hosted an Industry Day on May 29, 2019, with over 750 registered industry executives and leaders in over 450 companies in attendance. VA and OEHRM leadership presented a status update on EHRM modernization efforts, consistent with our and your demand for transparency. In coordination with OEHRM, Cerner Corporation, and Booz Allen Hamilton, our support contractor, informed attendees on the way to provide value-added programmatic support to the EHR modernization initiative. Now I want to highlight 3 important aspects of the EHR modernization effort, which will contribute to the overall success of the program. First, given the size, scope, and complexity of the EHR modernization effort, VA plans to deploy its new EHR solution in slightly under 10 years. The plan will evolve as technology advances and efficiencies are further identified. VA's approach involves deploying the solution at initial operating capability sites in the Pacific Northwest to mitigate risk and to solidify processes, procedures, and align enterprise initiatives before deploying to additional sites. Additionally, the IOC sites will further hone governance, configuration management, and a myriad of other implementation and change management strategies we intend to employ. VA targeted the Pacific Northwest region based on DoD's deployment of the EHR solution. By deploying in the same region, VA will be able to immediately demonstrate interoperability and reduce potential risk at the VA sites. Second, VA has developed and is instituting a change management strategy that involves engaging users in the field early in the process to determine their specific needs and quickly alleviate their concerns. Furthermore, OEHRM established clinical councils that includes nurses, doctors, and other end users from the field to support assessments and configurations of workflows. These clinical councils meet during the 8 scheduled national workshops, which educate this diverse frontline clinical end-user community and enable them to validate workflows, ensuring the new EHRM solution meets the VA's needs. To date, VA has completed 5 national workshops, with the remaining scheduled to occur throughout the remainder of the fiscal year. Finally, VA and DoD currently work with the Interagency Program Office to facilitate governance, collaboration, and decision-making. To further promote a comprehensive, rapid, and agile decision-making authority in support of interoperability objectives, DoD and VA are co-developing a joint organizational/management structure. To execute this strategy, DoD and VA proposed establishing a firm, Federal Electronic Health Record Modernization Office, responsible for effectively adjudicating functional, technical, and programmatic decisions in support of DoD's and VA's integrated EHR solutions. This strategy will optimize the use of DoD and VA resources while minimizing risk, promoting interoperability without compromising patient safety. As demonstrated by our efforts, it's clear that VA is committed to providing the best care to our nation's veterans, including access to a single longitudinal electronic health record. The efforts support one of VA's top priorities to modernize the VA healthcare system and ensure VA remains a source of pride for our veterans, beneficiaries, employees, and the taxpayers. Madam Chair, this concludes my opening remarks. I am happy to answer any questions that you or members of the subcommittee may have. Thank you again.
Thank you, Mr. Wyndham. Mr. Tinston, you're now recognized for 5 minutes.
Madam Chair and distinguished members of the subcommittee, it's an honor to testify before you today. Excuse me. I represent the Department of Defense as the Program Executive Officer, Defense Healthcare Management Systems. Our mission is to transform the delivery of healthcare, advance data sharing through modernized electronic health records for service members, veterans, and their families. In July 2015, the DoD awarded a contract to the Leidos Partnership for Defense Health to deliver a modern, interoperable EHR designed to share data with our federal and private sector partners. This modern, secure, connected EHR, known as MHS Genesis, provides a state-of-the-market, commercial, off-the-shelf solution consisting of Cerner Millennium, an industry-leading EHR, and Henry Schein's Dentrix Enterprise, a best-of-breed dental module. Deploying a capability of this magnitude requires extensive coordination and communication with our stakeholders and industry partners. It's a complex business. This is not simply an IT solution. It's a complex business transformation, and leadership is key to its success. The right people must be in the right place to make decisions and deliver solutions. MHS Genesis concluded its pilot deployment in January 2018. Our deployment to 4 sites, ranging in both size and capability, allowed us to observe the system, assess performance, and capture user feedback. We used this information to enhance system capabilities as we developed our strategy to deploy our next sites starting in September of this year. The VA's decision to implement the same EHR as the DoD and the United States Coast Guard will result in a single common record, eliminating the need for interoperability with VA. The DoD understands this decision demands extensive collaboration and joint decision-making between the departments and is working daily to ensure efficient workflows and standardized processes. Cybersecurity is one area of extensive collaboration and joint decision-making. The DoD sets the standard for cybersecurity, and PEO DHMS invests time and resources to ensure the common system meets that standard. Our cyber team is co-located with the commercial data center, which strengthens our federal and commercial relationships and allows for continuous cyber monitoring. As a result of our efforts, the VA will leverage this cyber posture and actively participate in critical decisions required to protect the environment. We also work closely with our VA partners to ensure we maintain system integrity. Recommendations for system enhancements are carefully evaluated by our joint work groups to minimize program risks and impacts. For example, we recently agreed to accept a Cerner software upgrade only a few weeks following our next site implementation. The timing of the upgrade adds complexity and risk to DoD's implementation, but it will ensure VA meets its scheduled initial operational capability in March of 2020. Understanding this, we knew it was the right decision for the successful implementation for both departments. Another example of our collaborative efforts is continuity of operations. The departments have agreed to a joint approach which provides both technical and programmatic efficiencies and will focus on clinical continuity of operations and IT disaster recovery. As a prior beneficiary and the son of a veteran, I am passionate about the mission and firmly believe we are on the right track to improve healthcare delivery for our service members, veterans, and their families. Working with the VA, the Coast Guard, and our industry partners, I am confident this team is committed to the successful deployment of a modern EHR. We are making daily strides in the implementation of an enterprise solution that will not only advance care for our beneficiary and veteran communities, but will ultimately lead to a longitudinal record focused on the patient, not where care is delivered. Thank you again for the opportunity to share our progress as we deliver a single common record for service members, veterans, and their families. I look forward to your questions.
Thank you, Mr. Tinston. Dr. Thompson, you are now recognized for 5 minutes.
Chairwoman Lee, Ranking Member Banks, and distinguished members of the subcommittee, thank you for the opportunity to testify before you today. As the Director of the Department of Defense, Department of Veterans Affairs Interagency Program Office, I am honored to be here. The mission of the DoD-VA IPO is to advance data interoperability across DoD, VA, and with private partner systems. Providing high-quality health care to service members, veterans, and their families is the IPO's highest priority, and health data interoperability is essential to improving the care delivered. A key component of meeting the unique needs of our beneficiaries and ensuring they receive the best care possible is making certain that no matter their status, location, or provider, their health data is readily available and accurate, or in other words, ensuring health data interoperability. The DoD and VA represent two of the nation's largest healthcare systems. Together, the departments serve over 30 million eligible beneficiaries, including service members, veterans, and their families. Over 60% of the DoD and 30% of VA beneficiaries receive care from the private sector. Currently, the departments share more than 1.5 million data elements daily, and more than 430,000 DoD and VA clinicians are able to view the real-time records of more than 16 million patients who receive care from both departments. The fiscal year 2008 National Defense Authorization Act directed DoD and VA to develop and implement electronic health record systems or capabilities that allow for full interoperability of healthcare data between the DoD and VA, instructing the establishment of the IPO to guide both departments in their efforts. In January 2009, the IPO completed its first charter, aiding the departments in attaining interoperable electronic health data. In March 2011, the Secretary of Defense and Secretary of VA instructed the departments to develop a single integrated EHR. In 2013, the departments decided to pursue modernization of their respective EHR systems. In December 2013, the IPO was rechartered to lead the efforts of DoD and VA to implement national health data standards for interoperability and to establish, monitor, and approve clinical and technical standards for the integration of health data between the departments and the private sector in accordance with the 2014 NDAA and in compliance with the DHHS Office of the National Coordinator for Health IT's guidance on standards interoperability for clinical records. The IPO acts as the point of accountability for identifying, monitoring, and approving the clinical and technical data standards and profiles to ensure seamless integration of clinically relevant health data between the departments and private sector providers who treat DoD and VA beneficiaries. In April 2016, the departments, with the IPO's assistance, met a requirement of the fiscal year 2014 NDAA, certifying to Congress that their systems are interoperable with an integrated display of data through the Joint Legacy Viewer, or JLV. JLV integrates data from the clinical data repositories of both departments, as well as data on beneficiary encounters with private providers who participate in National Health Information Exchange. The IPO monitors the usage of JLV and other interoperability metrics across the departments to track progress on data exchange and interoperability. The IPO collaborates extensively with ONC, other government agencies, and industry standards development organizations to advance the state of interoperability across the health industry. In 2018, Secretaries Wilkie and Mattis issued a joint commitment statement pledging to align strategies to implement an integrated EHR system. DoD and VA leaders chartered the Joint Electronic Health Record Modernization Working Group, referred to as the GERM, to develop recommendations for an optimal organizational construct that would enable an agile, single decision-making authority to efficiently adjudicate functional, technical, and programmatic interoperability issues while advancing unity, synergy, and efficiencies. On March 1st, 2019, the Joint VA-DoD Executive Leadership Group approved a course of action, plan of action and milestones, and implementation plan to establish the Federal Electronic Health Record Modernization Program Office, or the FIRM, in a phased manner in order to minimize risk. The FIRM will provide a comprehensive, agile, and coordinated management authority to execute requirements necessary for a single, seamless, integrated EHR, and will serve as a single point of authority for the department's EHR modernization program decisions. FIRM leaders will have the authority to direct each department to execute joint decisions for technical, programmatic, and functional functions under its purview, and will provide oversight regarding required funding and policy as necessary. This management model creates a centralized structure for interagency decisions related to EHR modernization, accountable to both the VA and DoD deputy secretaries. An interim FIRM director and deputy director will be appointed to work with the implementation team in transitioning joint functions into the FIRM once the FIRM has an approved charter. The interim leaders will manage and execute joint technical, programmatic, and functional requirements and synchronize strategies between the two department EHR program offices to ensure single, seamlessly integrated EHR is implemented with minimal risk to cost, performance, and schedule. The interim leaders will remain in these roles until permanent FIRM director and FIRM deputy director are appointed. The permanent director and deputy director will report equally to the Deputy Secretary of Defense and Deputy Secretary of Veterans Affairs. The IPO will continue to support the departments as it transitions to the FIRM in implementing a single EHR system to ensure a seamless, patient-centric experience that will ultimately lead to improved care for our service members and their families. Thank you for the opportunity to speak with you today. I look forward to your questions.
Thank you. I will now recognize myself for 5 minutes for questions. Perhaps my first question is, why the name change? Why do we just not, I guess this is for Mr. Tinston and Mr. Wyndham, why did we just not continue with the IPO?
Well, I wasn't here when the decision was made and the GERM working group was put in place. I understand why they changed it from GERM to FIRM. It just seemed an odd name.
Really confusing.
So internally, we talk about it sometimes as IPO 2.0 or a joint program office, but I can't really explain why we went with
Okay.
FIRM.
Ma'am, I can tell you, as we migrated from the GERM to the FIRM, only that the GERM had a connotation that did not reflect the clinical desires. And so, and then the federal element reflected, I think, an overarching responsibility within the federal space that encompassed DoD and VA. I think we're not hard and fast on any name, ma'am. We're just trying to be distinguished that we are doing something different than is perceived to be occurring now, hence the name. But I can tell you, Bill, I think I can speak for both of us. I don't think we have any
No, I
trademark
was just curious.
issues.
Yeah.
Yes, ma'am.
All right, thank you. Dr. Thompson, in your testimony, you stated that FIRM leaders will have the authority to direct the department to execute decisions for technical, programmatic, and functional functions under its purview. And based on that, it sounds like the firm has the authority to direct departments to execute the decisions that have already been agreed to. And I'd like to know, what is the firm's role related to issues that the departments failed to reach consensus on?
The intention of the firm is to be the deciding authority on issues.
Okay, thank you. What does that mean? Like who all, can you explain that further?
So the director and deputy director of the firm, who will be hired to report equally to the deputy secretaries of the DoD and the VA, will have the authority to make decisions that will then be executed by their respective departments.
Okay. Mr. Wyndham and Mr. Tinston, based on the DoD and IPO testimony, it seems like this firm is just getting operational. Have your respected agencies signed off on a charter? And is that charter operational, functional? And are there any establishing documents that you're able to share with us?
Ma'am, I would start by saying that the documents are in staffing, including the charter, as are the persons that will serve as the director and the deputy director. The concept that Bill and I primarily worked out, this three-phase concept, is a concept that was imperative to establish because it bounds where we feel greatest risk are. And so the three-phase concept is not to delay, but it is to support the proper, efficient, and timely movement of resources into the firm to support their decision-making process without compromising the risk in our present portfolios. So hence the three-phase. The second phase would be in support of Dr. Krupa's team solidifying workflows in alignment with DoD in that arena. And then the third phase would revolve around a critical milestone called IOC, Initial Operating Capabilities. As you know, until we demonstrate that it works in an operational environment, it really does not make sense to move resources until we solidified our strategy. So we are being consistent with what I've heard you say and others regarding accountability and regarding understanding that it is the end users that will solidify our success. And so taking in consideration those end users is what has driven our three-phase strategy. Bill?
Well, I think Mr. Wyndham addressed very clearly that the charters and staffing and the departments are considering their options for who the interim directors and intend to pursue permanent hires for the deputy and the director of the organization. But
Is there a plan that it can be shared with us on timing on all of this? On timing for the hiring and the resources that are being put behind this?
Ma'am, my understanding is that events are being coordinated literally as we speak to come over and brief your respective staffs on the details, where Bill and I will be co-leading an organization that comes over and literally gives you those details. We will be prepared to do so and offer those details and also discussion points at whatever detail you like and your staffs like.
Can I expect that in the next week or 2 weeks?
Ma'am, I'd like to kind of get with the DoD counterparts to really solidify that dates, and we'll gladly reach out to your staff through our legislative affairs to solidify that. I really wouldn't want to give you a date in the hearing and then I haven't agreed to mutually with Bill.
Okay. I'm over my time, so I yield, and I will recognize Dr. Rowe.
Thank you, Madam Chair. And just to start with grumbling a little bit, I don't like this room. We ought to have the next hearing at the Verizon Center. I feel like that's where I am. And two, I actually read this stuff, so I would appreciate you all getting this to me in a little sooner so I can sit down and read it. And I was able to read a few pages before the hearing, so I've got the grumbling over. There are huge challenges with this. Obviously, your organizational structure is one you're dealing with, two separate departments. One of the reasons that we are concerned here, I know Mr. Lamb and the chairman was not here when DoD and VA spent $1 billion to try to make Alta Vista interoperative and could not. So I think this is a step in the right direction. And I guess about 18 months ago, whenever it was, I went to Spokane and was able to be there at Fairchild and begin to see the rollout. It was a bumpy rollout, and it was not because the effort was not there. Look, I've saluted many generals. I didn't have near as much on my sleeve as General Payne as you do. So I know what they did was they saluted and said, yes, sir, we'll try to get this job done. Problem is that was when I saw that, I'd implemented an electronic health record in my own office with 70,000 charts in our practice. This was 10,000 basically healthy people in a system that really didn't seem like it worked all that well. And I know that you had to use the legacy reader to get back and get any information. And I guess my first question is, I know you, Dr. Payne, you're the champion for the providers. I do know that. Isn't that correct? You're the person that's looking after them, that's sitting down every day at the computer terminal.
Yes, sir, that's correct.
And do you think that the MHS Genesis, as it exists at Madigan, Bremerton, Oak Harbor, and Fairchild, are meeting the needs of the clinicians there now?
Yes, sir, I do. I think we've made significant progress since you saw the record in 2017. We've made some significant advancements. We learned the network stability was really, really important, and we're requiring that well in advance of go live now. We also learned that connecting all our medical devices was critical, and making sure those were all working and well established. All the cybersecurity standards were met before we went live.
Well, I know that slowed. I know that the security issue was one of the things that held it up, and I think that's hopefully one of the lessons learned that DoD can pass to VA, so they don't have to have the same problem that you had. Are you rolling out? Is what's in Spokane now the same as that you're going to roll out? I think it's in California and Idaho's the next rollout that DoD is doing. Is that correct?
Yes, sir. We start at Travis Air Force Base, Mountain Home, Monterey, and Lemoore Naval Air Station.
When does that? When do you start standing that up?
September
So
of
just
this year.
in a few
Yes, sir.
months.
It's right around the corner.
And will it be different than what you rolled out, or the same thing that they have now in Bremerton and Spokane?
I would like to say that the record has been advanced markedly over the past 2 years. Number one, and one of the great things about having a commercial off-the-shelf product is that we get regular updates, and we've taken those updates, we've integrated those across the system. We've also configured the system in a significant amount over the past 2 years. During the stabilization and adoption period, we added, corrected a lot of the problems that we were seeing initially in the sites. We've also, in the past year, conducted 14 sprint sessions that were led and directed by the clinicians at the IOC sites, telling us where they thought they needed the most help. So that has been really well received by the community.
Well, my concern when I looked at it was as a clinician seeing patients, and I was reading just, again, I got into here, which I find hard to believe, but it said, for instance, we can monitor the time a provider spends documenting care outside duty hours, and it was less than 3%.
That's correct.
Unless they're not seeing many patients. It certainly had been our experience in the private world. I mean, you're spending. I just saw a doc when I got on the airplane to fly up here at home, and he was lamenting how many hours they had to spend in entering data because he had a very busy primary care practice. The other thing before my time expires is I was reading that. Are we going to run the Vista and Alta systems with the legacy reader throughout the full 10 years of this until it's fully implemented, or would you turn the switch off in Spokane now so that you can rely on, I've got the information I need in front of me right now?
We do turn off, Bill, I don't know if you want to answer that about the legacy system turn-offs. You're probably better than me to answer.
So we run the JLV, the legacy viewer, while we're implementing the 23 sprints and getting to all the sites, and that's not 10 years, that's till 2023 when we get to all the military treatment facilities. JLV is actually embedded as a capability in the electronic health record that we're delivering so that we can get to have continued interoperability with the VA records as the VA is bringing their records over to the Cerner solution. So it will continue to be used and available, but it is what we're using for interoperability while we're in both environments.
Madam Chair, I hope we have a second round. I know I'm over my time, but that's, the idea is we've got the Cerner system off the shelf, and you're running a parallel system with it. Are we going to continue doing that? Because that is really a bureaucratic mess to keep up two systems. I yield back.
Thank you, Dr. Rowe. I now recognize Mr. Lamb for 5 minutes.
Thank you, and I want to echo Mr. Banks's thanks to the witnesses for appearing. We really do appreciate it. Mr. Wyndham, if I could just start with you and make sure I understand kind of where we are today in the timeline of everything. You noted in your testimony the contract that we're dealing with between Cerner and VA is what's known as an indefinite delivery, indefinite quantity contract. Do I have that right? And that was not competitively bid out on the market because Cerner was already involved with DoD and the government wanted to continue with Cerner, right?
Sir, VA leadership endorsed what's called a determination and findings that allowed us to sole source directly to Cerner Corporation in support of interoperability objectives, which involved being on the same Cerner Millennium platform. So that's what draws it. So a DNF drove the award of a sole source contract.
Right, got it. Okay, so that was never, it wasn't put out for bid. It was sort of following in line with what DoD has already done.
Correct.
Makes sense. Okay, so under this type of contract, if the go live at the initial sites does not happen in March 2020, is there any penalty in the contract for that? Like, will money that's been paid to them be recouped if it doesn't happen in March of 2020?
Sure. The question that you pose spawns a number of it depends. We are committed to the milestone identified in March of 2020. The IDIQ contract approach allows for flexibility that may be needed due to variability that's introduced that we flat out didn't know. As you know, we're doing current state reviews. Discoveries may be made such that you need to build the rectification of those discoveries or problems into your schedule. We maintain an integrated master schedule and an understanding of our critical path. We would know clearly when something was introduced to our critical path. Right now, our critical path revolves around clinical workflows as controlled by Dr. Krupa in making sure the end users embrace the solution and are educated on the solution.
Yeah,
So
I
the
get
bottom
that.
line
That's not
is-
really my question, though, if I could just interrupt you. My question is more from, I understand that you're doing everything to stay on schedule. My question is, if something happens on Cerner's end and they just don't perform, and March 1st of 2020 comes and they just don't go live, they're not ready, does the flexibility you're referring to include the flexibility to impose any sort of penalty or sanction on them for not fulfilling that goal in the contract?
So the simple answer, sir, is yes, this is a performance-based contract. If Cerner fails to deliver in accordance with the performance and the terms and conditions of the contract, we could withhold money. That would be the simple answer.
You can withhold future money.
We could withhold money. We wouldn't obligate additional money if we yet to rectify the issue that may be at hand. So that would not be good oversight on my part. So, sir, we can withhold money. We can withhold work in support of rectifying whatever concerns have been identified that may have caused our milestone to slip. So, but again, it depends. I don't want to say, because there's going to be discoveries that may spawn potentially a movement. But right now, we're tracking to our March 2020 go live, so I don't really spend a lot of time, sir, speculating what may happen. I simply say, if performance is breached on behalf of Cerner,
again, I hate to cut you off, but you
No,
know
sir.
time is
Yes,
limited.
sir.
I'm not asking you to speculate about what may happen. I'm just asking basic questions about the terms of the contract. And tell me if I'm correct here. It sounds like what you're saying is, in your understanding of the contract, if Cerner does not perform on schedule, VA has the ability to withhold funding from them going forward, yes or no?
That's correct. Yes, sir.
Okay. Now, Mr. Tinston or General Payne, whoever wants to answer this, when DoD went live at the initial sites and there were all the problems that they had, people were getting the wrong prescription drugs filled and, everything that was widely reported at that time, was there any action taken by DoD against the makers of MHS Genesis for those failings?
Congressman, I wasn't a part of the program at that point. I know that the DoD took those issues very seriously. We paused the implementation we went through, as General Payne described, the stabilization and adoption period, and then set to correcting those, improving the capability of the system, and then building a different strategy and a different approach to.
No, of course. I mean, you have to fix the actual product, and I can tell that's what you all are doing. My question, though, is we have contracted with someone to do this work.
Right.
And was there any sanction or penalty imposed for that initial?
Congressman, I'll have to get back to you on that. 'Cause
Okay,
I'm
that's
not
fine.
positive.
Now, I take it from everyone, and I'm basically out of time here, but Mr. Wyndham, you kind of referred to this. Do you believe that as of today, Cerner is on schedule to do the initial rollout in March of 2020?
Yes, sir.
Okay. And I just want you all to know that you use the terms, Mr. Wisdom said that we were looking to build an interoperability, or interagency program decision-making that was comprehensive, rapid, and agile. Mr. Tinston talked about being technically and programmatically efficient. You should know that that's not how the contractors described the current situation as it stands right now. They were with us last week. They said that decisions are slow. When I asked them open-endedly, what's the number one thing you need to succeed? It is faster decision-making by the two departments, which are two large departments. I can understand how they would be slow. But that is what is driving our interest in a more efficient process that is implemented quickly. So with that, Madam Chairwoman, I yield back.
Thank you. I now recognize Mr. Watkins for 5 minutes.
Thank you, Madam Chair. I represent Kansas 2nd Congressional District, think small towns, rural communities, and that makes expanded community care programs so very important. And so, Mr. Short, what systems and mechanisms do you have in place to assure that the exchange records with community providers runs smoothly?
Sir, with our contract with the Cerner Corporation, we have their health information exchange that they've used and many other partnerships that they have through the community providers. The process we're working through right now is before we go live in March for those processes and connections to be in place, which will grow the connectivity and ability for VA to have community partner access for data exchange at a greater level than we've ever had before.
That's good to hear. Thanks. And General Payne and Mr. Short, would it be fair to say that the considerations for that interoperability are different for the DoD as compared to the VA? And so the DoD is implementing systems for the first time while the VA is replacing systems. Would you either care to comment on that difference?
Just a clarifying question, sir. We're implementing systems for the first time. We've had, Alta, CHCS for 30-plus years. Centris are inpatient systems. I think what we are doing is taking multiple separate systems and bringing them together in an integrated system, which is a huge advantage for us.
And sir, I'll add to that. Currently today, DoD and VA both have an HIE, Health Information Exchange. They're much smaller what Cerner's going to provide for us later in this year, where DoD and VA will both be able to share the same health information exchange. As you know, VA has a lot of care on the outside with Mission Act, community care. That has potential to grow. Obviously, DoD's been on record many times. They have a large portion of their care on the outside. So when Cerner launches that next year, both DoD and VA will have ability to get a lot more records from the outside than we ever have.
And just as a clarification, General, what major systems or mechanisms do you have in place to exchange medical records with TRICARE providers?
I'll start, and then I think Mr. Tinston might be able to add. We use Joint Legacy Viewer today. I want to say the number is over 50 healthcare information exchanges we have established with the civilian community, and that's going to expand, as Mr. Short pointed out, as we move into the Commonwealth into the future. There'll be thousands of health information exchange, and we're exchanging information with both our civilian counterparts as well as the VA on a daily and hourly basis. Mr. Tinston?
Well, the number's 59 HIEs that we're connected to right now. When we move to Commonwealth and when we're joining VA in the Cerner environment, we get the added advantage that any HIEs or networks that we're connected to, that the VA connects to, we also share the advantage of that same connection, and vice versa.
Thank you, Madam Chair. I yield my time.
Thank you. I now recognize myself for 5 minutes. I'd like to focus a little bit about patient identification. As I understand it, the VA and the DoD have different patient identification standards, understandably, in their medical record number formats. We heard that there's been more than some conversations about standardizing them. Mr. Short, what is the status of those conversations, and have you been able to reach a consensus?
Ma'am, DoD and VA work together to create what's called the Joint Patient Identity Management Service. We've taken the back-end systems that we've had connected for many years, we've enhanced them, created some new business rules. The current connections that DoD has feeding MHS Genesis, as they call it, the EHRM platform, we've taken that connection and made modifications to it. As part of that, we've also had to make sure that every veteran had a unique identifier. DoD issues out an EDI-PI identifier to all soldiers, sailors, airmen, Marines, but many veterans in the past didn't have those. So as part of this, we also had those identifiers issued to all veterans that ever existed that we have a record of. They could have been a World War II veteran that passed away 30 years ago. If we have a record of them, they now have been issued this identifier. We've completed that in the last couple of months. We're down to about 300 or 400 left that had to go through manual checks because someone with a similar name had similar Social Security numbers, and they had to manually double-check those. So that has been put together, and in the next couple of months, that'll go into testing. So that service is together. That way, we feed one system of one identity service to the common EHR. Since you have the same population, or very similar populations, you needed a common interface for identity going to the system for patient safety. So we engineered that early on in the system. We put it in place, and testing will start in a couple months.
Great, thank you. Now that the Mission Act has been implemented and more veterans are going to be receiving their care in the community, has there been any conversation around standardizing patient identifiers with the VA and community providers? Mr. Short.
I'm sorry, ma'am, I didn't know if the question was we currently today, we work with the HIEs I mentioned earlier, the Health Information Exchanges, and Cerner has Commonwealth, which General Payne mentioned. We currently today, when we send someone out in the community, we have the advantage, we've already identified them before we send them out. So that part is taken care of. When it's accepted, when the community partner accepts them, that our community partner exchanges that we work with validate those identities also. So we have the advantage of, we kind of manage that process, or not kind of, we manage that process through the community care referral process. So from that standpoint, we keep that. We have the Social Security number, as well as the veteran identifier mentioned earlier. We actually track a number of identifiers on everybody, and we double check that inside the VA system. The Identity and Access Management Team under VA OI&T, they have a whole process where they use a large number of identifiers to validate those from the outside.
Okay, thank you. I'd like to now turn to some infrastructure questions. And after the contract between VA and Cerner was signed last year, Cerner completed a current state review. The reports generated indicated that obvious concerns with infrastructure, including insufficient network capability, outdated hardware, necessary facility modifications. Did the VA conduct their own assessment in concert with Cerner?
Ma'am, the VA staff went with Cerner when they did their current state review, so it was done in partnership along with our government and contract staff. And then, once that was completed, there was subsequent reviews done by VA OIT for the technical pieces of it and VHA facilities as well.
So I understand now that VA has plans with MITRE to perform an assessment as well. Has that assessment been completed?
Ma'am, I know of no plans with MITRE to conduct a technical assessment. We're using a number of other entities, but MITRE has not been one. We've got MITRE personnel on our staff who participate in some of these assessments, but we have not contracted specifically with MITRE to go do these assessments.
Okay, so no MITRE request to do an assessment?
No, ma'am.
Have there been any updates made to these assessments?
Ma'am, I'm going to defer to John Short, my CTIO, for that.
Yes, ma'am. Cerner did their initial review. We had some feedback. We did our review, and we completed that. Cerner updated those current state reviews. And again, as I mentioned, OIT and VHA facilities also did those reviews. Since then, we had a meeting in the Pacific Northwest to go over all the facility work that needed to be done and put that all under plan and action.
Thank you. I now recognize Dr. Rowe.
Thank you, Madam Chair. A couple of quick questions. Any concerns about the 10-year rollout, because technology changes so fast now? Are we afraid, do you think that the rollout now is going to look like in 2019 like it's going to look in 2027 or 28? Are you going to be able to adapt and make those changes as inevitably technology will change?
Dr. Rowe, I think you've highlighted an important element of the IDIQ contract, indefinite delivery, indefinite quantity, where we get to leverage the commercial advancements that Cerner undertakes in its commercial environment with our own portfolio without incurring additional expenses. So we expect to evolve with the commercial market to stay current. We will evolve with the market, and technology, as you just highlighted, moves very quickly. So we plan to use things like cloud computing and APIs and things that may become the prevailing methodologies in the technological arena.
And Mr. Tennyson, I hope that the mentality to listen to providers in the MHS system about why they don't like it, I think we should, and not just re-educate them about what's good about it, but have these providers out there that can change it and make it a better system. Are you doing that? Have you all done that? And Dr. Payne, you also may want to jump in.
So the way the DoD has set the program up subsequent to the IOC sites is designed to do exactly that, right? I have a team of IT business system implementers who make sure the IT's right and make sure that it reflects what the medical facilities need and the clinicians need. And then General Payne takes care of that. So we're two elements of getting this right, and he works with the clinicians to make sure that on the implementation side we're doing the right thing.
What I found out in implementing an electronic health record was you had the IT people that didn't really know what we needed, so they put everything in there. And I know I would get a stack of paper this much, and I'm thinking somewhere in this pile of, you know what, there's some information I might be able to use if I can find it. And that was the frustration I had with it, because we have these cut and paste things that you end up with misinformation being in there, and you never can get it out. And so are you listening to providers to say, look, I need this amount of information in my little silo right here. I don't need every question that's ever been asked anybody in their life every time I see them, which is what these records did. And it wasn't, I don't think it was the IT folks' fault. I think they just didn't understand what was clinically important to me as a doctor.
As I mentioned to you about our sprint sessions, I think the frontline clinicians, we also have clinical communities that are working with the VA councils in configuring the record. One of the great things about MHS Genesis is it is configurable. We can adjust the system. As a provider, you can adjust it to your likes and dislikes. We're working, the other part I really like about this is we're not an isolated, just isolated in DoD. We're participating with Cerner client universe. We visited the University of Missouri, the Tiger Institute, to see how they're operating. We're about to go to Memorial Hermann Hospital in Texas to see how they're implementing MHS Genesis. It's one of the safest hospital systems in the country. And we are also, our ophthalmologists are working with Cerner to help devise the ophthalmology workflows. So I think this record gives us an opportunity we've never had before. And with our VA colleagues, I think there's a huge amount of power in that.
And this is just a question, Mr. Wyndham. I read this last night. I have no idea what it means. VA is leveraging several efficiencies, including revised contract language to improve trouble ticket resolution based on DoD challenges. Could you translate that into something English?
Yes, sir. Sir, that was pre-contract award, so there's no contract modification. Basically, our partners in DoD shared with us very forthright and honestly some of the challenges they were dealing with trouble ticket management in the Pacific Northwest. And we were able to add terms and conditions to our contract to facilitate a high level of performance and review by Cerner in adjudicating ours sooner rather than later. So it really is just a lesson learned, sir. I'll be more clear next time.
Thank you. Last couple of things. One is a big challenge, Dr. Thompson, you know this, across the country is interoperability. It's not DoD and VA. It's a private sector. How do we share information? And unfortunately, a lot of people don't want to share information because the information they have is power and they can leverage it for money. But it's critical for us to be able, as clinicians, to be able to share clinical information across VA to the private. Look, it does me no good to have a mission act if I'm sitting out here and I can't get any information from the VA. And by the way, after I see the patient, if that information doesn't end up back at the VA, it doesn't do the patient any good. I'm going to leave one question. You can think about it, both of you, because my time's expired. But in this rollout, what's the major thing that keeps you up at night? And I'll end on that. I'll yield back.
Thank you, Dr. Rowe. I now recognize Mr. Lamb for 5 minutes.
Thank you. And if you would like to answer Dr. Rowe's question, that's, I think, a major question on all of our minds, just sort of current assessment right now. What's our biggest obstacle? Mr. Wyndham, if we could start with you. Between now, let's say between now and March 2020, what's the biggest thing that keeps you up at night?
Sir, I've listened to this committee and I've listened to the end users intently. And it's about user adoption. The technology will work. The technology will support. The embracing of the end user to our change management strategies, our education strategy, training strategy, that's our critical path element. So the critical path element keeps me up. I think Dr. Krupa and her team are doing a great job. I'd like to pass the question over to her, if you don't mind.
I appreciate that. I was going to move to her.
That's
anyway.
what keeps me up.
And Dr. Krupa, are you the one who oversees the 18 councils and the input from the clinicians?
Yes.
Okay. So if you could just let me know sort of what's at the forefront of your mind, but also what are the most recent examples that you're hearing from them of issues?
Yeah, I think the biggest challenge for us in VA is, as it's been mentioned, we are going from a CPRS system, which people are very accustomed to a commercial system. So there's been a lot of education about what does that mean? How does the commercial system work? How do we even speak the same language as the commercial system? I think we're now getting into a phase where the councils understand that. They're really hitting their stride in terms of understanding how the system works and are able to really see the places where we can accept commercial best practice and in places where there are specialized things that VA needs to do for our patient population and for our mission.
And what are some specific things that they've identified recently?
So there's some things, some basic things like service connection. No one else in the world cares about service-connected veterans except for VA. That's not something that's in a commercial system to start with. We have a lot of programs in VA that other commercial systems don't have. We do things with PTSD, with blind rehab, a lot of comprehensive mental health.
No, I'm sorry to interrupt. I understand why the VA system is different than the commercial clients. What I'm asking is there a recent example you know of where a clinician has flagged for Cerner and for you, this thing that you already have programmed will not work for me for this reason?
There has certainly been, probably in every council, there's something that has been flagged that says, we need development in this, we need configuration in this to make sure that it meets the VA VA standards.
But do you know what those are?
There's a whole list of those. So those are all the things that we're working on now with Cerner to rectify.
Okay.
Are-
And is it planned in the schedule where before March 2020, some of these clinicians, either on the councils or otherwise, are actually going to go through like a dry run testing in front of the computer?
Yes, sir.
Can you tell me how that is scheduled?
Sure. So part of the council process is that they validate their decisions from the last time around. So they're constantly validating and reviewing the decisions they made before they move forward with the next phase. Then we have an extensive testing timeframe. People from the councils have already been identified that will be the testers, so that we'll make sure that their intentions are met in the product before it's ready to go out. And then we'll have extensive testing in Spokane and Seattle, including mock go-lives and a variety of validation events to make sure that it's ready to go.
And do you know when that starts in relation to March of 2020?
The testing will start in November.
Okay.
That's our current plan.
Thank you. Mr.
Congressman
Windham,
Lamb,
did you-
may
yeah,
I
go ahead.
add, just real quickly, is that we knew at the inception, there's certain capabilities that aren't delivered as part of the Cerner integrated solution. We knew that. Things like prosthetics, things like long-term care, these are capabilities that will be interfaced with the existing system as Cerner and us, to be frank, walk through the coding process to actually integrate it into the solution. So no capabilities will be lost. We may interface in the interim and then replace the capability in the future as part of our overall implementation strategies.
Right. No, I understand that in general terms. I guess I think I'm just a little bit surprised that nobody can name a specific instance of where a end user doctor said to you guys, hey, the program falls short in this area of something that I do and we need to get a fix, and how it was fixed. It seems to me that's what you're describing that you want to be taking place. But I'm just a little concerned that we don't have specific examples of that. And you can feel free to get back to us later. I understand we're putting you on the spot. Madam Chairwoman, I yield back.
Thank you. I'd now like to recognize Mr. Roy for 5 minutes.
I thank the chairwoman. I appreciate you all being here and taking your time to address this committee, and apologize for missing the first part of it, so hopefully I won't repeat anything. We've got redundant duties in another committee. Fortunately, this is a committee where we actually, on a bipartisan basis, tend to try to do something productive, so I'm glad y'all are here. Mr. Windham, I might start with you. I understand that the VA is pursuing a best-of-suite strategy with the Cerner contract and not a best-of-breed strategy. Could you please explain what that means to you and how y'all decided to pursue that path?
Sir, a best-of-breed is a individual set of capabilities that are basically daisy-chained together, where often the government becomes the integrator of those products. Where a best-of-suite is an integrated solution that is built, that is developed, that is coded to perform in an integrated fashion such that there is no integration requirement in between the individual components of the solution. And so Alta and CHCS on the DoD side, that is an example of two different products where the DoD is the integrator between the two. So that's how I would describe it to you, sir. Best of breed is a set of solutions that are daisy-chained together to deliver the requisite end state, where a best of suite is an integrated set of elements where the end state is delivered without the interactions in between each stage.
So quick question, quick follow-up on that, though, isn't it the risk sort of putting all the eggs in one basket and versus, having, other alternatives and options that we might be able to have, especially modern technology with APIs and all the different ways that we can, integrate across platforms? Is that not putting all the eggs in that one basket, or no?
Sir, we have not restricted innovation in any way, shape, or form on even a best-of-suite platform. So if there's capabilities being delivered in the market that we, the VA, want to leverage, we have the ability to present that to Cerner solution set as a requirement in fulfillment of VA mission objectives, and pursue integration of those, if you will, enhancements or improvements. So a best-of-suite does not imply you can't inject new capability or innovation into the product line.
Well, on a follow-up then, Mr. Tinston, I assume DoD also has a best-of-suite strategy. Is that correct? And if so, can you please walk me through your thought process there?
We do, in fact, have a best-of-suite strategy, and the idea is that you get an integrated set of capabilities, as Mr. Windham said. there may be a best product in this area, but what works best in the combination of capabilities that we're delivering to clinicians and the patients. So
Okay.
integrating.
Slightly, I'd love to engage on that probably for hours, but in our limited time, Mr. Wyndham, back to you. How do you define vendor lock-in as it pertains to electronic health records and health IT companies, and what would it mean for the VA to become locked into a particular company?
Sir, I'm very sensitive in my, not only my DoD life, but now to restrictions on the use of intellectual property. You know, the open sourcing, the things that allow us, if you will, to inject capabilities and not be bound by a solution that we've contracted for. So the having access to code, having access in an unrestricted way to bringing in the requisite solutions, whether it be apps, applications that are now very prevalent, that's where I deem vendor lock is. And in our terms and conditions of our contract, we've greatly inhibited vendor lock by promoting Cerner opening up their gateway to allow better solutions, enhancements to the product line that they may not only want to incorporate on behalf of the VA before their commercial customers as well. So, sir, hopefully that gets to where you were looking for.
Well, on a more specific basis, does buying the Cerner Millennium EHR pose the risk of vendor lock-in?
No, sir. The terms and conditions, again, we've got an innovation CLIN contract line item number. We've got, again, I don't, this is a VA requirement. We drive the requirement. We drive the behavior of Cerner and performance of the terms and conditions of the contract. We have no desire to give up on the innovative talent that the VA brings to bear, nor the solutions that are being developed in the market today. So we believe we have that relationship in the terms and conditions of our contract, and we will exercise it as necessary down the road to support, again, our veterans.
And relatedly, does the VA getting rid of its patient portal, My Health EVET, and adopting Cerner's patient portal pose the risk of vendor lock-in?
Sir, I'm going to defer that question to Dr. Krupa, but that's not our strategy. So we're not getting rid of our patient portal. Okay. We have a methodology that we're going to move forward with that leverages the qualities of both patient portals in our strategy. The key is that this is not a turnkey solution set. We can't just turn one thing off and turn something on. We know there are benefits in the way our system performs. It is not our intent at all to reduce the capabilities being provided to our veterans, but to enhance the capabilities. So, Dr. Krupa, ma'am, did you want to touch on patient portals specifically?
Certainly. So we've done a side-by-side comparison of what the Cerner portal offers, versus My Health EVET. We're working on a strategy of how we can ensure that the veteran experience is as close to the same across the country as we can make that. There will be some transition time, but we're basically working with Cerner to upgrade their portal to make sure that it offers the information and the ease of use of My Health EVET. So we're still working, outlining that strategy, but we're constantly working with Cerner to make sure that their product gets better to serve our veterans.
Madam Chair, I'm a minute over my time. Thank you.
Thank you. The subcommittee has copies of the current state reviews, and we've received updates, and we appreciate that very much. I just want to make sure that we have every infrastructure report. So besides the CSRs, is there any other analysis review about infrastructure readiness?
Man, we have a joint infrastructure plan that was co-authored by the OI&T office, headed by the CIO, and also John Short and our team. We gladly share that with you because what we feel is that the synergy between OI&T and our office is essential. Yeah. They are the managers of the network today, so we can provide that if you don't have that. John, did you have any other documents that you're hiding from me?
No, sir, no hiding documents, but OIT, as I mentioned, there was other reviews that were done, and the Office of Information Technology did create a report on Seattle, Spokane, and American Lake. We can get that for you.
Can we get that? Thank you.
Ma'am.
In the past, you've indicated that you will have the infrastructure projects completed within 6 months of go live. And then you just stated that, I just want to ask for clarification, you're going to do testing in November. Do you need the full infrastructure done for the testing, or are you going to sort of test modules while you're completing? Like, how's that timing work out?
Yeah, ma'am, there's testing in the operational environment and testing outside. So the testing outside the operational environment does not require the infrastructure to be ready to go. We are sticking to our plan of the infrastructure will be ready 6 months prior to go live. And so the testing environment that we build in support of testing in a non-operational environment is separate with possibly some connections or interfaces. John, did you want to touch on that anymore?
Yes, ma'am. Just for clarification, the infrastructure needed for go live will be ready in that time. But there's still some additional infrastructure work that'll be completed later, not required for go live, but for a better user experience overall, some of those things, but not necessary for operation. But all the ones necessary for testing on site and necessary for operations on site will be done in time.
Do you worry that if you implement the infrastructure for operation, but it's not optimal, and ultimately you said the thing that keeps you up at night is the end user experience, and so if you don't have the proper infrastructure in place, you actually set yourself back?
Ma'am, I think you're right on point. It goes hand in hand. What we do is we build plans to support being ready as intended. We would owe you that transparency to your staff if we're not meeting what we think our objectives are in support of that. I've indicated quite a few times that IOC is a period of time, initial operating capability. What is available at go live, we will continue to update the infrastructure to deliver capabilities throughout the IOC process, which is a period of time vice a single point in time. So I wanted to make sure that was understood. And then obviously tech refreshes will be ongoing to support the system operating at the optimal level. As you know, we're going to be running Vista and Cerner in parallel for a while. And so we know that the infrastructure will not run better with two systems, but we intend to, we intend to make the appropriate and prioritize decisions on infrastructure upgrades.
So what is your timeline on just beginning the infrastructure construction at IOC sites and the ordering of the hardware?
Ma'am, a lot of that is already in taking place. Some devices will be arriving soon. Some cabling has been done. Wireless infrastructure has been replaced at one facility. So all that work is actually ongoing already. We can provide you a full schedule, ma'am.
Yeah, and ma'am, we would gladly provide you a full schedule so you can see all the spreadsheets that are being worked. We are leveraging, this is where I compliment the CIO and the OIT. We're leveraging their contracts to the maximum extent possible. I mean, we're talking about commodity-type hardware that they already procure, that we're simply being able to leverage their vehicles for efficiencies on our side. So that's actually a time-saving mechanism that is giving us schedule back that we appreciate the CIO support in.
Good to hear. Thank you. I now recognize Dr. Rowe for 5 minutes.
Thank you, Chair, very much. And we here on this committee are here to try to help roll this out, not get in the way. But I would like to be invited to one of your sites with no PowerPoint presentations, and so I could just sit down with nurses and doctors and other people using the system and actually see how it works. I personally would like to do that. And to Mr. Roy's question, to follow up on what he was doing, and I guess anybody can get this here, what other functions will this system do? I mean, is it going to, are you be able to contract with it, schedule with it, appointments? What else is the Cerner system capable of?
So this is really a very full set of capabilities that we've bought from Cerner. So it will have the electronic health record, the clinical portions of that. It will have the revenue cycle side of things, so scheduling, appointments, registration, billing, those types of things. It will have, we have Healthy Intent, which is the data analytics.
Did you say we'd be able to do billing also?
It'll be part of the billing process, yes. We have Healthy Intent, which is the data warehouse side of that, where we will be able to do reporting and analytics. It has extensive management modules, so that will help clinical managers understand the flow through clinics, that you know, as you mentioned, that the time that providers use on the system. So we'll be able to say that this particular provider is having trouble getting through this order set, and we need to go help and train them and help them understand the system better. So it has an extensive suite of both management and clinical uses.
Well, this is a huge, look, this is a monstrous undertaking that you all are doing, both of you. And there are going to be some bumps in the road. There is no question about that. So please just share them with us. Look, I've been down that road, know how it is. It's disruptive to the practice and the clinicians. So if you run across things like that, don't sweep them under the rug. Come to this committee, subcommittee, and let us know about it. We're here to try to help you provide what you need to get your job done. And I think it's one of the most important projects that's going on now. At the end of the day, it's not about technology. It's about patient care. It's about going into the room and seeing a patient with their ailment and providing the absolute best quality of care we can do. It's not about, nobody cares about Wi-Fi and 5G and all that. They just want to get well, and they come see me. They don't care how they do it or come see the doctor. That's what you do and what I do when we go in. But our job is to make sure all that other stuff works so we can do that. And so I would encourage you to be as forthright with us as you can be. Mr. Wyndham or Mr. Tinston, either one, it doesn't matter, but or both of you can answer this, but who decides, or have you all decided who's going to lead the firm? Has that decision been made, and who made it?
To my knowledge, Congressman, that decision has not been made. So I think the two departments are in discussions about who's going to be the interim leadership for the interim director and the interim deputy director for the firm, and then they're going to pursue permanent hires in the future.
It's okay, so that hadn't been made yet. Lastly, and I'll finish up and yield back my time. You've been thank all of y'all for being. It's been a very good hearing. Do you see, Mr. Wyndham, any delays that could happen right now? Are you out looking out your windshield? Do you see anything that would hold you up? Because if you do, to me, that's fine. If it takes another month or two, I'd rather have you get it right than get it quick and get it wrong.
Yes, sir, and you've been clear, sir, in a number of hearings, and we appreciate that support. I will tell you, March 2020 is where we're tracking for go live. I keep pointing to the clinical decision-making process that Dr. Krupa leads. It's about when they're ready. When they're ready is when we will go deploy this thing. And so we've got our last workshop, I think, in September, and we'll be looking toward where we are in aligning the workflows with DoD being involved in those. And I think we obviously would owe you an interaction to say, sir, here's where we are in the workflows. But I view that as our critical path item. And as you know about the integrated master schedule process, my critical paths, right, we can work myriad of things in collateral and parallel, and we're doing that. So that critical path element for me is the clinicians and their embracing of the solution coming forward. So can I come back and see you in November?
Absolutely.
Yes, sir.
Hope so. Hope
Okay.
I'm here in November. One last question. When will you know it's interoperable? When will because we're going to have folks separating from the military during this time, and they're going to be leaving. When will we know you can punch a button and move that medical record over from DoD to VA?
Yeah, I think, and I'll defer to John after I make just two remarks, is that, sir, I think that's one of the benefits of us being in the Pacific Northwest simultaneously with the Department of Defense, is that you should be able to walk from Madigan go live. You should be able to walk from Madigan into American Lake and the Seattle Medical Center and the Man Grandstaff, and you ought to be able to bring up each other's records. That's where we are what we are striving for. Let me turn.
I should be able to make a 3-foot putt, but I can't.
Well, yeah. So that's what our testing is going to be in support of. That's what our strategy is going to be in support of, and we will welcome you out there for the go live session to prove that to you.
When will that be?
Yes, sir.
When will that be?
March of 2020.
March of
sir.
2020.
Yes, sir.
I yield back. Thank you.
Thank you, Dr. Roy. I now recognize Mr. Roy.
Thank you, Madam Chairwoman. Just to follow up with a few more questions we started with, Mr. Wyndham, does using Cerner's healthy intent product as the repository for all veteran health data pose the risk of vendor lock-in? Just continuing the conversation about lock-in.
Sir, we selected a solution to benefit the veterans and the active duty service members. So the vendor lock thing, I don't know enough about the inner workings of healthy intent to be able to give you that. So if you don't mind, I'll take the lookup,
Okay.
and I'll defer to John and Dr. Krupa for maybe their assessment of the product.
Sir, when we were negotiating the contract, we required Cerner, upon VA's request, to extract the data from Millennium and Healthy Intent into the form and structure that we require it in. So if in the future we decided to go somewhere else, we could have the data extracted and go somewhere else. And obviously, that would be a whole effort in itself, but we do have that ability, so it's not locked into their system.
Okay, and relatedly, in general terms, I just want to go back to Mr. Tinston. I understand DoD plans to buy Healthy Intent, but has not done it yet. And is vendor lock-in a consideration in this decision?
So we are, in fact, we have a joint team with the VA for the implementation of Healthy Intent. We're setting up the environments now. I am not worried about lock-in with Healthy Intent. As John Short just mentioned, the data is not Cerner's, but importantly, with Healthy Intent, it's a set of capabilities built on other products, some of them even open source products that are not Cerner exclusive products, so I don't see a risk of vendor lock-in here.
So just to clarify, the questions that I'm asking about vendor lock-in are not meant to be critical of Cerner or anything along those lines. I think, obviously one of the leading companies out in the industry, it's meant to just focus in on some of the, concerns that we might have. This project's very large and difficult, and we want to complete the basics before turning attention to other stuff. But I believe innovation is really important. And as I know, I think all of you do. Believe it or not, I have a master's in management information systems from my previous life, which was in 1995, so it's about as useful as, having a putter in my hand right now. I do care about these issues and think about them at least analytically in the way that I would when I was in that realm of my life. So the question I'd have here that I'm trying to understand is how we're getting the kind of competition and innovation that needs to continue through this process, right? I mean, particularly for veterans, I know I hear in my district all the time about their concerns about under choice and mission being able to go access private sector healthcare and having trouble doing so, and trying to make sure that we've got the best health records to make that process as smooth as possible. So one question here, Mr. Wyndham, is do you know what Cerner's market share is now?
I do not, sir.
Okay. My basic understanding is it sort of being the upper 20s or something in that zip code of the market. And then I assume the answer will be no, but do you know what the market share would be if the military health system and VA both finish implementing Cerner nationwide? Do you have an estimate of what that market share might look like?
I do not, sir.
Okay. We have some rough estimates that might put it in the sort of mid to upper 30s. And again, nothing inherently wrong with that per se. We've got a lot of industries where there's some significant market dominance. I think it's just a question that should influence at least some of our thinking about making sure that there's the kind of innovation that's necessary. And we're not talking about monopoly here, obviously, but we are talking about concerns about making sure there's continued innovation. So this seems to have been one of VA's considerations when it negotiated the contract with Cerner. And so I want to ask you one question. The contract says VA will have access to Cerner's data architecture, not just the data in the system which VA should already own. VA hailed this as a big victory when the contract was signed. What is Cerner doing differently to give VA this access, and how is VA using it?
Sir, on the access to the data models and what we've done already, data migration is the main area where this hits first, and that is there's many elements to data migration, many steps. So when we did this, we had to map VISTA data to the Healthy Intent data model, which CMO staff did with Dr. Krupa's staff did with Cerner, and then that had to be mapped to the Millennium data model so Cerner can move that data. So the first steps of that have been done, and now Cerner's taking the next steps over the next couple months to move that into the Healthy Intent model and into the Millennium model. And by having access to the data models to be able to map that, we can actually make use of all of VA's legacy data in VISTA back to 1981, so it can be used by DoD and VA.
Anybody else have anything to add to that? Okay, well, I think, thank you, Madam Chairman.
Thank you. Well, this wraps it up. I just want to thank you all for your time today and your testimony. Certainly, we understand how incredibly complex and important this project is, and the opportunity to improve care for not only our active service members, but our veterans. And certainly the example that Mr. Tinston provided with the nursing rapid response that helps save a life is obviously what we look for as the future of this project, and the great opportunity we have, not just within the VA and the Department of Defense, but for healthcare, not just across this country, but throughout the world. So not a small undertaking. You know, last week, I just want to reiterate this. Last week, the contractors said that their single greatest risk to their success was the timing and the ability to make decisions. And, you know, we've had the IPO, then it was the germ, now it's the firm. But still today, my understanding from the questions that were answered today, that this is really still just a concept and not an actionable plan at this point. And then layered on top of that, we have the IDIQ contract, which, you know, according to Mr. Wyndham, you have, you know, clear responsibilities that are Cerner's versus yours. And so we're happy to hear that you are confident you're on schedule for the March 2020 rollout. So my concern is, as we get closer and closer, and if we start to miss deadlines, there's going to be a clear decision point when we want to understand who's responsible. And without a clear plan on this firm, and I'm going to reiterate that again, it really puts us and the taxpayers at risk, because, you know, there's going to be a point where Cerner's going to say, no, it's your fault. We're going to say, no, it's your fault. At what point? That's why it's so important that we have this governance structure in place so we can understand, and we have one point of decision-making and one point that can say, this is what happened, and we're either going to hold Cerner accountable or we're going to hold ourselves accountable. And clearly, especially as Dr. Rowe said, you know, if we know this is a huge undertaking, and when we come up to bumps in the road, we'd rather understand them than find out about them after the fact. And so I need to close this out by reiterating, as soon as we can see the actionable plan on the firm, will give us a lot more clarity and comfort as we move forward and work together with you to try to meet the March 2020 rollout. So best of luck. Continue the great work. Thank you all for your service to our country and our veterans and our active military members, and we look forward to continuing the conversation. Thank you. The members, before we end, will have 5 legislative days to revise and extend their remarks and include extraneous material. This hearing is now adjourned.
We're going back to the